cells. Basket and stellate cells are produced by proliferating cells in the cerebellar white matter. The cortex of the cerebellum consists of Purkinje cells, Golgi 2 neurons. Neurons produced by the external granule cells reaches its definitive size at birth. And deep cerebellar nuclei such as dentate nuclei reach their final position before birth. So you would expect the cerebellum in a definitive shape at birth. So the development is continuing in the intrauterine life. So what you need to know in terms of the cerebellum, that it is going to arise from the rhombic lip, and as the pontine flexure is going to deepen, the rhombic lip is going to come together and it's going to form the cerebellar plates. Once the cerebellar plate is formed, there is a groove in the center which is going to give rise to the vermis, and then you have two cerebellar hemispheres. Initially, you have the three layers as you see anywhere in the brain: neuroepithelial layer, mental layer, and marginal layer. This neuroepithelial layer is going to give rise to the cells which will migrate to the surface of the cerebellar cortex or the cerebellar surface, giving rise to the external granular layer. And this external granular layer is a proliferative layer which is going to give rise to cells like Purkinje cells, granule cells. The basket cell and stellate cells are going to come out from the white matter. The nuclei which you see in the white matter, the dentate, and they are all migrating from the external granule cell, but they would take time to reach into the white matter. So by the time of birth, these definitive cerebellar structure would be there. Okay? Everybody, any questions? Yes.
But the mental layer itself, would it disappear or?
Would it disappear? It would disappear. The only layer which is going to be there is the external granule layer, and you would have the marginal layer which is going to give rise to the white matter. Okay. So in the mesencephalon, so now we have done the rhombencephalon, we are going to talk about the mesencephalon. Mesencephalon would have basal plates which are going to give rise to the they are going to give rise to two columns. One is the general somatic column, which is mainly responsible for the muscles to supply the oculomotor nucleus and the trochlear nucleus, which supply the muscles of the eye. And there is a general visceral efferent, which is the parasympathetic nucleus, which is the Edinger-Westphal nucleus, which you see coming out from the basal plate. The marginal layer from the basal plate is going to give rise to the crus cerebri, and that crus cerebri is going to give rise to the fibers which are going to pass from the interior part of the midbrain. The alar plates are going to give rise here to the superior colliculus and inferior colliculus. The superior colliculus is responsible for visual responses, and inferior colliculus is responsible for the auditory responses. So the basal plate is responsible for giving the trochlear and oculomotor nucleus and the Edinger-Westphal nucleus, and the marginal layers from the basal plate is going to give rise to the crus cerebri. The alar plates here are going to give rise to the superior and inferior colliculus. Now, we are going to talk about the prosencephalon or the forebrain. So we know that, yes, red nucleus is a migratory nucleus. It has migrated from above, from the basal nuclei. So the red nucleus and the substantia nigra are the ones which have migrated down from the basal nuclei. So they are not actually the part coming out from the alar or the basal plates. Okay? So now we come to the prosencephalon, which is the forebrain, and prosencephalon consists of telencephalon and diencephalon. So initially you have a forebrain vesicle which is called prosencephalon, and this prosencephalon is going to give two outpouchings, and these outpouchings are going to be called as telencephalon. The central part of the prosencephalon is called the diencephalon. So you have two cup-shaped outpouchings which are coming from the the prosencephalon, these are called the telencephalon. They are going to give rise to the cerebral hemispheres, while the central portion of the prosencephalon is going to give rise to the diencephalon. The other thing which we said about the prosencephalon, that there would be no more basal plate. So what you would have is the alar plates only. So you have the alar plates and the roof plate, but you don't have the basal plate. So here in prosencephalon there is nothing coming out from the basal plate. You have the alar plates which have increased in size, and there is a roof plate which is going to give rise to the choroid plexus and things like that, which the roof plate is going to give rise in the rhombencephalon. We saw that roof plate form the choroid plexus of the fourth ventricle. Similarly, you would have a roof plate in the prosencephalon, and you would have the alar plates, but you would not have basal plates. So basal plates are gone at the level of prosencephalon. So first we are going to talk about the diencephalon, which is the central part, and this diencephalon has a roof plate, and this roof plate is formed by the ependyma and a layer of pia mater, and this is going to, the layer of pia mater is vascular, so it is going to give rise to the choroid plexus of the third ventricle. Also the caudal part of the roof plate is going to give rise to the epiphysis, which is going to give rise to the pineal body, which you see overhanging at the back. So you know that the roof plate is going to give rise to the choroid plexus of the third ventricle, and it is going to give rise to the epiphysis, which is the pineal body and epidural nucleus, which we talked about before. The alar plates are going to give rise to the thalamus and hypothalamus. But these alar plates would be divided into a ventral portion and a dorsal portion. The ventral portion is going to give rise to the hypothalamus. The dorsal portion is going to give rise to the thalamus. So the diencephalon, which we see, has a roof plate, which is going to give rise to the choroid plexus of the third ventricle, and it is going to give rise to the epiphysis, which includes the pineal body. The alar plates have a ventral portion and a dorsal portion. The ventral portion of the alar plates is going to give rise to the hypothalamus. The dorsal portion of the alar plates is going to give rise to the thalamus. So you can see it here. This is the thalamus, and this is the hypothalamus. So these are the alar plates. So this is the thalamus, this is the hypothalamus. This is the roof plate, which is going to give rise to the choroid plexus, and it is going to give rise to the epiphysis, which is the pineal body there. Okay, next is, from the diencephalon we also have the formation of the pituitary, and we also have the formation of the pituitary stalk. So hypophysis is also going to come out from the diencephalon, but there are two parts of it. All of you know that there is an anterior pituitary and there is a posterior pituitary. Posterior pituitary is going to be formed by the diverticulum from the diencephalon, or from the floor of the hypothalamus there would be a infundibulum or the stalk, which is going to go down, and the anterior pituitary is going to come out from Rathke's pouch, which is the ectoderm around the oral cavity, which is going to go up, and it is going to give rise to the anterior pituitary. Those two pouches, when they are going to unite, you have the pituitary gland, the anterior pituitary coming from Rathke's pouch, the posterior pituitary, which you see here, is coming from as a diverticulum from the diencephalon. Both are ectodermal in origin. Okay. Final thing is, in terms of the development of the brain, is the formation of the telencephalon. And the telencephalon, you know that it's basically an outpouching from the prosencephalon vesicles. These are two vesicles which are going to be formed, and they are going to give rise, as they are going to increase, they are going to form the cerebral hemisphere. So you have frontal, parietal and occipital lobe, and in the center of these, because this is a cup-like outpouching, the center cavity of the telencephalon is going to give rise to the lateral ventricle. So that's why lateral ventricles are hollow structures inside the cerebral hemispheres. So that's all what you need to know in terms of the development. We will deal with a little bit of some of the abnormalities. So one of the major abnormality is called the holoprosencephaly, and holoprosencephaly refers to a spectrum of abnormalities in which a loss of midline structures results in malformation of brain and face. So you would not have two cerebral hemispheres, you might have one cerebral hemisphere. So both lateral ventricles are united. So there is one cavity of the lateral ventricle. And similarly, you might have, not two eyes, you might have a single eye, a single nostril. So it's a midline deformity where you would not have two telencephalic vesicles, you have one telencephalic vesicle. So you have one cerebral hemisphere, one eye, one nose. So this is a very rare type of abnormality, but these are group of abnormalities which are called holoprosencephaly, which means that loss of midline structures. Then we have another abnormality which is called the Scheissencephaly. It's a rare disorder where you would see large clefts in the cerebral hemisphere. So you see the cerebral hemisphere, it has large clefts and it can result in large losses of the brain tissue. So, but it's a very rare type of abnormality which probably you would not see in your practice. The ones which you would see more commonly are meningocele, meningoencephalocele, and meningohydrocele. When we say meningocele, it means if the skull is not completely fused, there is a part of the meninges protruding out, that is called the meningocele. And if you have meningoencephalocele, it means meninges with the brain tissue is protruding out, it is called the meningoencephalocele. If you have a part of the ventricle also protruding out, so you have meninges, you have the brain and a part of the ventricle protruding out, then it is called meningohydrocele, hydrocele. All are caused by an ossification defect in the bones in the skull. The most frequent effect of the bone is the squamous part of the occipital bone. So this is the part of the bone which is not usually fused, and you will see a bulging from here. Only meninges bulge out is called the meningocele, but if the defect is large, part of the brain or part of the brain with the ventricular cavity can also bulge out. The defect is about 1 in 2,000 live births. So it's not that common, but it is still not that rare also. So this is the three types which you can see. This is the meningocele where you can only see the meninges. Here the brain tissue is also there, and here the ventricular cavity is also coming. So this is hydroencephalocele. Sorry. Then we come to this abnormality which is called the exencephaly, which is characterized by failure of cephalic part of the neural tube to close. Now, if there is a failure of the cranial part of the neural tube to close, this will result in that the vault of the skull will not be formed. And if the vault of the skull is not formed, the brain tissue is exposed to the exterior, and as a result it would start to degenerate. And as it is going to degenerate, it is called the anencephaly. So exencephaly is characterized by failure of fusion of the cranial part of the neural tube, which will result in the vault of the skull not forming. The brain tissue is going to be exposed to the exterior, and as a result the brain tissue is going to degenerate, resulting in anencephaly. But you must remember, the brain stem is still intact, and as the brain stem is still intact, your vital functions can still happen. Since the fetus lacks the mechanism of swallowing, the last 2 months of the pregnancy are also characterized by hydromenos. So you would have increased water in the amniotic fluid, The reason is that the fetus is unable to swallow. The abnormality can be recognized on radiograph since the vault of the skull is absent. Anencephaly is common abnormality. It is about 1 in 1500 that occurs 4 times more often in females than in males. And like spina bifida, it can be prevented by just giving 400 micrograms of folic acid. So if you, yes. Hydrocephalus is characterized by an abnormal accumulation of the cerebrospinal fluid within the ventricular system. In most cases, the hydrocephalus is characterized by an obstruction of the aqueduct of Sylvius. So, most of the time, when you see the congenital hydrocephalus, there is an obstruction in the aqueduct of Sylvius. So, it's an obstructive type of hydrocephalus. This prevents the cerebrospinal fluid of the lateral and the third ventricle to the fourth ventricle, and you know that the CSF goes into the subarachnoid space through the openings which are called the foramen Luschka and Morgandi. So if it is not going to go to the fourth ventricle, it cannot go into the subarachnoid space and can be absorbed. So this is an obstructive type of hydrocephalus. Usually you would see large lateral ventricles and you would see a large third ventricle. So this is most common in the congenital type of abnormality which you see if you see hydrocephalus. The Arnold-Chiari malformation is a caudal displacement of the cerebellar structures through the foramen magnum. And Arnold-Chiari malformation occurs virtually in every case of the spina bifida cystica. So if you see a spina bifida cystica, you would always suspect an Arnold-Chiari malformation. And in that Arnold-Chiari malformation, there are parts of the cerebellum which pass through the foramen magnum. Microcephaly is described as a cranial vault that is smaller than normal. Since the size of the cranium depends on the growth of the brain, the underlying defect is in the brain development. Causation of the abnormality can be genetic, it could be autosomal recessive, it can be due to certain teratogens. More specifically, it can be because of toxoplasmosis. So toxoplasmosis, exposure to toxoplasmosis in the earlier part of pregnancy can result in microcephaly. So microcephaly is a small head or brain. It is usually an autosomal recessive disease, but it can be because of exposure to teratogens and like toxoplasmosis. Okay, so this we have talked about the structural damages to the brain where you can actually see. But there are many defects of the CNS where you would not be able to see any external manifestations. But you still foresee mental retardation. So you, in terms of you do an MRI, the brain looks perfect. But there might be problems with the mental development and there could be mental retardation. On the other hand, you can find some problems, external problems in the brain, but you still find no defects at all. So you can get both, either diseases where you see extreme mental retardation, but externally the brain looks alright. And on the other hand, you might see an external abnormality in the brain and you see no motor, sensory or higher mental deficits. For example, corpus callosum may be partially or completely absent without much functional disturbances. So there could be complete or partial loss of corpus callosum, which is an association fiber between the two cerebral hemispheres, and you would find no abnormality at all. Likewise, partial or complete absence of the cerebellum may only have a slight disturbance of coordination. On the other hand, severe cases of mental retardation may not be associated with morphologically detectable brain abnormality. For example, patients of Down syndrome, you might find the brain is perfectly alright, but they have a genetic problem which results in mental retardation. Thank you very much.